Good day and welcome to part 3 of cardiac constants. In part 3, we're going to focus on the supraventricular dysrhythms as well as heart blocks. And that will help guide us to understand what we're going to see in patients in the critical care unit as well as patients who are presenting with COVID virus. So let's work together to overcome any concerns we have about diagnosis and treatment of cardiac dysrhythms. So to begin with, I want to review the salient points that we talked about in part 1 and part 2, that persistent tachycardia is always a warning sign. Pay attention to it. Always investigate. Does my patient have pain? Are they agitated? Do they have a high fever? Or is that tachycardia compensatory for tissue hypoxia? I should always know that answer, and I should be able to communicate that to my treatment team. Rapid heart rate, however, as a compensatory response, remember, may limit significantly the filling of the ventricle and therefore the ejection from the ventricle. And we call that, of course, stroke volume. So I want to remind you the key to learning here is persistent tachycardia is always a cause for concern. It's a prodrome or a warning signal for us that we may have a patient who is getting ready to deteriorate. And if we see a patient with bradycardia who is also hypotensive, that is always abnormal. So we must be aware of those clinical signs and symptoms as we progress through cardiac rhythm states. So I'd like to remind you about normal physiology. The normal physiology is that the sinus node is in charge of the heart. The sinus node depolarizes at a rate of 60 to 100 beats per minute, or electrical impulses per minute. That impulse is gathered in the AV node, communicated to the bundle of His, and then out into the Purkinje fibers. So just to make sure we have a good visual, we just remind ourselves, starting at the sinus node activates, it's the closest to threshold. And remember, threshold is the door that gets opened in the cellular channel, allowing ions to move in. Sinus node is closest to threshold, so that's where depolarization is designed to begin. That communication goes through the intraatrial tissue and is then gathered in the AV junction or the AV node. In the AV node, part of that responsibility is to slow the impulse conduction to allow time for the atria to contract. And as that impulse then transitions down the bundles into the Purkinje fibers, activating both the right and the left ventricle almost simultaneously. Now, anything that interrupts the transition of the impulse to the right and left ventricle will actually give us a visual of either incomplete or complete bundle branch block. But that's for another time. So we just again review that electrical system, and we remind ourselves that we have a specific electrical tree. Every cell in the heart has the capability of initiating depolarization, but typically all those cells in the atrium, cells in the ventricle, are controlled by the early active depolarization of the sinus node. So sinus node first. Sinus node is comprised of pacemaker cells. Those pacemaker cells are designed to reach threshold first. If the sinus node does not reach threshold, then the AV junction will take over control of the heart in the normal pacemaker process. And if there's failure of both sinus node and AV junction, the Purkinje fibers will fire in order to maintain an electrical depolarization of the heart, because remember, without depolarization, you can have no contraction. That's a bad thing. All cells in the atria and the ventricles, all cells have the capability of actually depolarizing the heart. But when cells outside of the normal depolarization tree actually activate the heart, we're going to call that a dysrhythmia. Dysrhythmia is concerning, of course, because it interrupts the normal appropriate cycle from the top of the heart through the atria, atrial contraction to fill the ventricle fills, and from Actually, from the apex up, the contraction of the ventricle boluses that blood into the pulmonary artery from the right heart and into the aorta from the left heart. But it is vitally important to remind oneself our number one goal is to keep all those atrial and ventricular cells that are not part of the normal depolarization tree. We want to keep those under control. So I'm going to introduce a little Barbaraism here, and that is the cell who reaches threshold first. Remember, threshold is when you open up the gates and allow ions to come into the cell, creating depolarization. The cell who reaches threshold first is in charge of the heart. Now, we don't want any cells to be in charge of the heart except the designated ones from top to bottom. But dysrhythmia occurs when cells are unbalanced. Unbalanced because of electrolytes, unbalanced because of injury, and unbalanced because of hypoxia. And that's what generates dysrhythmias. So remember, electrical path, sinus node, AV junction, Purkinje fiber, ability to activate electrically all cells in the atria, all cells in the ventricle can actually reach threshold first and take charge of the heart. For one beat, which would be a premature depolarization, or for a rhythm, which typically is going to be a tachycardic rhythm either in the atria or in the ventricle. So, salient points so far. Going back to what we talked about in 1 and 2, there are two major groups of dedicated cells. Primary, secondary, and tertiary pacemaker cells. That would be sinus node, AV junction, and Purkinje fibers. And then any myocardial cells that are not in the pacemaker tree. Primary pacemaker cells actually escape. What that means is depolarization from above does not depolarize the pacemaker cell. So if there's a failure in the sinus node, the junction will take over, and the junction has a rhythm that's lower than the sinus node. That's called an escape rhythm. It means escape from death. Non-pacemaker cells will take over whenever they're unstable. And it's important to remember, atrial cells are potassium and calcium dependent for depolarization. That's the electrical event. And ventricular cells are sodium and calcium dependent for depolarization. So it's really important to take that into the clinical framework, which means you have a responsibility to know what the drug you're giving does. Atrial tachydysrhythmias respond to beta block, potassium channel antagonists, and calcium channel antagonists or blockers. Ventricular tachydysrhythmias respond to potassium and sodium channel antagonists or blockers. So atrial dysrhythms respond to amiodarone, primary, amiodarone as a potassium channel antagonist, and diltiazem as a calcium channel antagonist. Or you might even be using verapamil, which is an older one. Ventricular tachydysrhythmias, we actually, in general, will initiate amiodarone. If patients are refractory to amiodarone, the potassium channel antagonist, our cardiologist may order lidocaine, pronestal, quinidine, all of which are variable sodium channel antagonists. Those are no longer the drugs of choice to initiate for persons who have ventricular dysrhythmia because there are so many secondary pro-arrhythmic effects of those sodium channel antagonists, and you need a cardiology consultant to tell you to add those to your drug armamentarium. Okay, so when we're looking at dysrhythm, there's definitely a key to success. The key to success is to try to do it the same way every time. Looking at the P to P interval, the R to R interval, which then allows you to calculate the rate. The rate of the atria and the rate of the ventricle should always match. To look at that rhythm, is it fast or is it slow? To find the P wave and make sure that the P wave is upright in all leads except for AVR. The P wave should be upright, and that PR interval from the beginning of the P wave to the beginning of ventricular depolarization, a Q or an R, doesn't matter, Whatever the beginning of ventricular depolarization is, the PR interval is constant, and it's repeated again and again and again in the same framework of time. Then we look at the PQRS correlation, meaning does every P wave have a QRS? So remember, I'm looking at P to P, P1 to P2, P2 to P3, P3 to P4, P4 to P5, and then I'm looking at R, R1 to R2, R2 to R3, R3 to R4, R4 to R5, and then I'm looking at the constancy, that every P is followed by a QRS, and that the rate between, or the interval between the atria and the ventricle is constant. And then we look at our basic R to R interval, and we determine where the pacemaker of the heart is. So remember that the P wave causes atrial depolarization. The P wave is a signal, of atrial depolarization, and the P wave promotes atrial contraction. The PR interval is normally 0.12 to 0.20. That's 3 small boxes to 5 small boxes. And that initiates, that's the measurement of the time it took from the impulse starting in the sinus node out into the atria and the time it takes to get to the ventricle. So it has to go through that AV junction. That's why we look at the PR interval, because it tells us about the AV junction. The QRS is the signal of ventricular depolarization. And remember, you must activate the ventricle to have a myocardial response or a contraction. Always have depolarization before contraction. Can't have a contraction without depolarization. The QRS interval is normally less wide than 2.5 small boxes, but we don't consider it to be abnormally wide unless it's more than 3 boxes, which would be 0.12. That measures the amount of time it takes for the ventricle to completely depolarize. Now remember, contraction follows depolarization. So atrial contraction occurs during the PR interval, and ventricular contraction occurs during the ST segment. So we think these are very important for us in terms of helping us to understand electrical to mechanical, which is why we have to have a good understanding of rhythm and rhythm disturbances, because the electrical event affects the mechanical response. And the mechanical response is what sustains and maintains A, your stroke volume, and B, your stroke volume times heart rate, which is cardiac output. So let's take a look at this method and how we actually make these measurements. So we know that when we're looking at an EKG trace, what we see are 2 major components. Straight lines, and straight lines are telling us there is no electrical activity, there's no voltage difference, and current isn't traveling through the heart. So we have a straight line before the P wave, we have a straight line after the P wave, and we have a straight line after the QRS, and we have a straight line after the T wave. That's the way it's supposed to be. No current, no electrical conduction. So straight line, straight line, straight line, and straight line. Whenever we're conducting current, we actually see a shift from the baseline. The first shift we see is the P wave, and then we have a delay, the PR segment. The PR segment is that delay time that allows for the atria to contract to ultimately fill the ventricle, and then the QRS begins, and then after that electrical event, we have a straight line again, that's the ST segment, and that is the time that the ventricle is contracting. Following that, we see repolarization known as our T wave. So we think about 3 major common components: electrical activation of the atria, that's the P wave, electrical activation of the ventricle, that's the QRS, and electrical repolarization of the ventricle, that's the T wave. Aha, you asked. You said, why don't I see the P wave repolarize? Well, that's because, just like the P wave, the repolarization of the atria is small. And it's happening during the time of the QRS. That's why you don't see it. But indeed, the atria do repolarize. So let's remind ourselves that what we are seeing is the influx of ions into the cell, changing the electrical component. We call that depolarization. And then when we shift the ions back out of the cell, coming back to our normal resting state, That's known as repolarization. So what I need for you to remember very, very significantly is that the straight line before the P wave, that's called the TP interval. The straight line after the P wave and before the ventricular depolarization, that is called the PR segment. And the electrical line after the QRS, called the ST segment, should always be equal to each other and at baseline. Now that's really important because when there's a shift in the PR segment and or a shift in the ST segment, that means that something is wrong. And we're going to pay a lot of attention to that, although we may not leave any of this course being able to diagnose a 12-lead EKG. What we are going to be able to do is recognize the signs and symptoms that occur when we have patients who have pericarditis, ST segment elevation, MI, or non-ST segment elevation. So that's going to be a really important concept. And I'm only introducing it here because, as you recall, this content is about dysrhythmia. Okay, so we always want to remind ourselves that if we're counting boxes on a horizontal axis, each box in a 25 sweep speed, each box is worth 0.04, yes, of course, I missed my math. 0.04 seconds each box. So remember, 3 to 5 boxes for the PR interval. And if we're measuring boxes on the horizontal in a standard signal, each box on a horizontal is worth a millimeter. 10 boxes is 10 millimeters, also known as a millivolt. So that just reminds us how we look at our EKGs, that we're thinking about our segments, our intervals, and we're going to apply that now to our rate. So one of the important aspects when we look at EKG is just to actually uncover what the heart rate is. There are many ways that we can do that, but generally the easiest way is within a 6-second strip. You count the peak of the R wave and you multiply that number by 10. That gives you a basic heart rate evaluation. And when we look at our EKG analysis, what we're going to remind ourselves is we're going to apply this as well to our atrial rate. So finding your P wave on that EKG, you will actually see P1 to P2 to P3 to P4, and all those P to P intervals. So you just look from 1 to 2 and then move to 2 to 3 and then move from 3 to 4, making sure they're all equal. And the P to P interval should equal the R to R interval. So the atrial rate is the measured distance between the P waves. And that measured distance between the P wave should equal the measured distance between the R wave. And you can have a little bit of variability, that's still considered normal, but that variability is just one box variable. So we do have some irregularities when we take a breath, etc. We might have some irregularities, and we want to be aware of that when we're measuring our EKG. I'm so sorry. So if we were to take a look from first P to second P, and I'd love to be able to show you on the strip, but I'm assuming you can read the P wave. So I'm going to say it's 5 boxes, 10 boxes, 15 boxes, 20 boxes, 30 boxes. There's 30 boxes between the P to P, okay? So now I'm going to expect that from P2 to P3 there are 30 boxes, which there are, and between P3 to P4 there are 30 boxes, which there are. Now I look at my R wave and it should be just about the same, 5, 10, 15, 25 or so. I guess I counted incorrectly, but my R to R should equal my P to P. Now, if there was a way for me to show you, what I'd really want to be able to do is point to the R1 and R2 and make a mark on an index card and then move my index card from R1 to R2, from R2 to R3, from R3 to R4, and making sure that the marks on my index card also equal P1 to P2, P2 to P3, P3 to P4. That tells me the atrial rate matches the ventricular rate. Okay, so now when you think about looking at this patient And what you can see is P1, which is the first full P wave you see, to P2, and you measure that. And then you move your card along. So from P2, you'd like to go to P3, but whoops, you have a premature depolarization and it has a P wave, so we're going to call that a premature atrial complex. Okay, now taking a look at this patient, and actually I'm not going to look at this patient. You know why? Because this patient actually has a pacemaker, and we're not ready for that yet, but we'll revisit this strip just a tad bit later. Okay, so remember, when we're looking at our EKG, we're going to measure P to P interval and calculate the atrial rate. Then we're going to match that to the R to R interval, and we want that rate to match. That means every P has an R, and the P to P rate and the R to R rate are equal. This is the simplest thing that we do with EKG, but I find most people don't actually think about it. Then we look at the PR interval, and we look for the PR interval to be constant. Then we measure the width of the QRS, and ultimately we're going to measure the time from beginning of ventricular depolarization, whether there's a Q wave or not, to the end of ventricular repolarization. And of course, that is known as the QT interval. Now we're going to talk more about the QT interval when we talk about ventricular dysrhythmia, because it's going to be so important in terms of understanding who's at risk. And in critical illness, as well as in COVID, this is going to be an important signal for us to understand the potential for patients to have life-threatening dysrhythmias. So again, we're going to come back every time when we look at EKG, and we're going to talk about P to P interval, R to R interval, PR, QRS width, and QT interval. Okay, so if we just take a look at this patient, we can say this is, we'll pretend that it's a 6-second strip, and we have 1, 2, 3, 4, 5, 6 R's. 6 times 10 is 60. Then we're going to look at our P to P from P1 to P2, move our index card over, P2 to P3, move our index card over, P3 to P4, and so on. And then we will calculate our atrial rate, and then we will match it to the ventricular rate. So you've made only 2 little marks on an index card from P1 to P2, and you move your index card along to make sure every P wave falls on time. Then you move that up to the peak of the R wave and make sure that it matches every single time. Now what that tells you is every P has a QRS, and atria and ventricle are connecting together through the AV junction. That's what's so important about doing this in a standardized manner that allows you to do good measurement. A little bit hard to teach on video, but we're going to get some actual practice when we do a WebEx webinar that's live, so that we can actually evaluate in this way, and we'll understand it even better than we already do. Okay, so first and foremost, we talk about normal sinus rhythm. All is right with the world. This is an image from the ATOM website that gives us great visual images. And what that reminds us is that if your electrical activity starts in the sinus node, communicates through the AV junction, through the bundle branches, and out into the ventricles, that your rate will be between 60 and 100, and that your atrial depolarization, your P wave, will be right on time. Every P will have a QRS, and you will fall within the normal rate calculation. Now, of course, we all know that your sinus node can fire fast, it can fire slow, it can fire irregularly. But what's really important is to actually appreciate, does every P have a QRS? And is the PR interval constant? Because if we can answer those questions, we can almost always diagnose dysrhythms. Okay. So with normal sinus rhythm, remember the rate is normally 60 to 100, and the rhythm is absolutely regular, and it stays right on time. P to P equals R to R, and it stays right on time. Every P has a QRS, every P looks the same, every QRS looks the same. The PR interval is typically 0.12 to 0.20, and the QRS with less than 0.12. We'd like it actually to be less than 0.10. Okay, so now let's just take a quick look at this patient. Now this is a 12-lead EKG, which means it makes it quite hard to diagnose dysrhythm. 12-lead EKGs are really more designed for us to look at abnormalities in those straight lines, the T to P segment, the PR segment, and the ST segment. But let's have a go. First and foremost, we're going to take a look at a 6-second strip, and that's going to be also very hard to do because we don't have a rhythm strip. But I would love for you to see, if we're looking at lead 2, which is the most common lead that we monitor, that every P has a QRS, that the P to P rate equals the R to R rate, and that the PR interval is constant. So just looking at lead 2, you can see that here. You should never diagnose dysrhythm from a 12-lead EKG. That should always be diagnosed with a rhythm strip, which your EKG tech can run at the bottom of the 12-lead EKG. So typically we'd like to see that in lead 2 and V6. So we'd like 2 rhythm strips, lead 2, V6. We're going to get so much more information from those 2 leads that help us diagnose dysrhythmia. Can't diagnose dysrhythmia effectively from a 12-lead EKG without a rhythm strip. Okay, so now we're taking a look at a rhythm strip. Yay! And what we look at here is our P to P interval, and we're looking at 2 separate leads. So what you're actually seeing is a lead 2 and a V1. Lead 2 and V1, which is also a very good choice. If you're looking at a V1 lead, that means your brown electrode actually is on the 4th intercostal space to the right side of the sternum. Brown electrode should never be in the center of the chest. Don't know who taught you that. That should never be so. And we will talk about lead placement a little bit more when we talk about the 12-lead EKG and STEMI, non-STEMI. But important to remember that you always want your leads to be in the correct position if possible. Okay, P to P equals R to R. Every P has a QRS, and it's right on time. And the PR interval is about 0.18, so we're looking good here. This is a nice, normal sinus rhythm. All right, now we take another look at this EKG, and I'm going to say thank you to Marion Williams, who gave me some of these fabulous images, or posted these fabulous images. So I do have some things that come from her as well as from our own data bank. And we're going to just take a look at, again, looking at the regularity of R to R. Does the R to R and the P to P equal? Is the PR interval constant? And is my rate within acceptable limits? So your rate here is somewhere around 70. It's within acceptable limits. Your P to P equals your R to R. Your PR interval is constant. You marched, making those marks on your index card from P1 to P2, and then moving your index card P2 to P3, and so on, and then actually matching your R to R in the same exact way. So that's a really good strategy for evaluating our patient's EKG. Now let's talk about how we're going to use information. So first, we just talked about basic evaluation of P to P, R to R. What is the rate? Does every P have an R? What is the PR interval, and is that constant? And what is the QRS width? Okay, so that's the beginning. But now we have to talk about whether the rate is fast or slow. So remember, first and foremost, does every P have a QRS? Is the PR constant? And what's the QRS width? So if we divide this categorically into fast and slow, fast meaning greater than 100, slow meaning greater than 60, that's the rate, okay? And we're all pretty good at looking at the rate of our patients, I'm quite certain. And remember, just run a 6-second strip, multiply times 10. Okay, so if you have tachycardia and the width of the QRS is less than 0.12, we're going to call that narrow QRS tachycardia. We often will see this in 2 ways. First of all, regular. If it's regular, we are assuming, if it's regular, that it is above the ventricle. So it's a supraventricular dysrhythm. We call that, we might see it as sinus tach if we can identify the P wave clearly. If we can't identify the P wave clearly, but the QRS is narrow, we're going to call that supraventricular. Supraventricular includes atrial flutter and paroxysmal atrial tachycardia. So all that means is it's a narrow QRS and it's really fast and it's regular. That's all. That's all. So when I'm reporting to a physician over the phone, I have a patient with a heart rate of 140. Their QRS width is normal. It's a regular rhythm with a narrow QRS. If it's regular, fast, narrow QRS, it's from above the ventricle, and it typically is sinus tach, paroxysmal atrial tach, or supraventricular tachycardia, not standardly atrial fibrillation. Now, if my patient has a rapid rate, but it's irregular, it often and most frequently will be atrial fibrillation, and we call that atrial fib with a rapid ventricular response, or RVR. So that means a person who has atrial fib, whose atria is depolarizing 300 to 500 times a minute. And thank goodness your ventricles aren't conducting that amount of depolarization. So atria is, whoop, 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 whoop. Whoops, sorry, I always mess up here. There we go. Whoop, 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 whoop. Whoop, 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 whoop. Whoop, 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 whoop. That's your atria and your ventricle. The only way I can make it live on a video. So forgive me for all my noises, but hopefully that helped. The atria is fibrillating 300 to 500 times a minute, which, by the way, means atria doesn't really get full, and it rarely actually communicates its blood effectively down to the ventricle, which is why one of the things that we're most concerned about with patients who have AFib is that they actually will have stasis of blood in the atria, and that will form a clot. And that's one of the reasons that when we have patients with AFib, we always want to be certain they haven't already formed a clot in the atria, because if we defibrillate them or actually cardiovert them, we may actually loosen the clot and actually expulse the clot up into the LV, or the clot may have formed in the LV and then it gets loosened up into the arch of the aorta, into the carotid arteries, causing a stroke. So that's why we're so worried about atrial fib, because there's so much blood stasis, because you don't have effective contraction, that you form clots. And those clots will enter into the arterial circulation, not the venous circulation like the right side, but into the arterial circulation. So we have a lot of worry about that. And when we look at somebody with echo, we're looking for an LV thrombus or an LA thrombus, most particularly an LV thrombus. Okay, so atrial fib, rapid ventricular response, irregular. Atrial flutter, that is variably that flutter wave, which is very regular in the sawtooth pattern, but which is irregularly conducted through the AV junction to the ventricles. Multifocal atrial tachycardia, sort of like multifocal premature ventricular depolarizations. You have many areas in the atria that are reaching threshold first. That's almost always a prodrome for atrial fib or atrial flutter. So we pay a lot of attention to that. Paroxysmal atrial tachycardia, so one focus in the atria but firing really fast. One focus rather than multiple focuses. And of course, patients who have PACs or PVCs. So I really don't like to call it PAC or PVC. That's the common lingo. But we're not talking about the contraction. We're talking about the depolarization. So it's actually a premature atrial electrical action or a premature ventricular electrical action, which interrupts the regularity of your heart rhythm. Okay. So narrow. Now we go to wide. Wide QRS tachycardia. If it's regular, the most common cause of regular wide QRS tachycardia is ventricular tachycardia. But a secondary cause of wide QRS tachycardia, regular, is supraventricular initiation that is actually conducted through the junction in a right bundle branch block pattern. Now I'm going to give you just a little history here. A very well-known cardiologist, Dr. I think it's Henry Wellens. Wellens is who I know, and that's W-E-L-L-E-N-S if you want to look it up. Dr. Wellens did a reverse analysis of all patients who had been diagnosed with ventricular tachycardia and found that about 85 to 90% of those patients actually had supraventricular tachycardia with the wide QRS conduction. Now, you know what? it doesn't really matter that much to us today, because if you have a wide QRS tachycardia and you are hemodynamically unstable, we're going to defibrillate you. So we're not really differentiating what it is. But the second thing that's really wonderful, so I don't know how many of you listening to this are over the age of 45, but those who've been nurses for 30 years or 25 years will remember that in early ACLS, you had to be able to differentiate supraventricular tachycardia from ventricular tachycardia to pass your megacode. Now we no longer have to do that, and you know why? Because when you have a tachycardia that's wide QRS, you're getting one drug, and that drug will be a potassium channel antagonist, and that's amiodarone. So for wide QRS tachycardias, we're going to give amiodarone. Now we might have done that also for the narrow QRS tachycardias, but we have a lot more choices. With narrow QRS tachycardia, meaning arising from above the ventricle, we might choose to give you beta block therapy, we might give you diltiazem, we might give you verapamil, and we're going to give you amiodarone. For wide QRS tachycardia, our drug of choice is amiodarone. And the other thing that we can do, of course, for wide QRS tachycardia is that we will consider defibrillation. Now, you might say now, well, where does adenosine fit in? Adenosine fits in the narrow QRS tachycardias. What we're actually trying to do with adenosine is halt all energy to all cells to allow time for the sinus node to take charge of the heart. That's what adenosine does. That's why when you give adenosine, if a patient is awake, they say, oh, mule kick me, because their heart stops. Their heart stops. For a very short period of time, adenosine is used in the energy molecule that is necessary for transport of ions across the cell. You give adenosine to stop the heart to allow the sinus node to take back over. So that's very important for us to remember about adenosine. We should always have an expectation that the heart's going to stop, but that expectation is it stops for less than 6 seconds, usually less than that, but we have to be very concerned because we don't want to have a prolonged effect, of course, from adenosine, and it doesn't always allow time for the sinus node to take back over. That's why we start with 6 and then we give 12. Okay, so wide QRS tachycardia, regular, VTach, and supraventricular tachycardia conducted in a right bundle branch block pattern, which we call aberrant. And in fact, most of the time, when we're looking at patients, we're diagnosing VTach, not most of the time, but many of the times, it's actually a wide QRS tachycardia supraventricular. So we're so grateful to have amiodarone because that helps us with either one of those issues. Now, if you have an irregular wide QRS tachycardia, okay, that could be paroxysmal, meaning multiple places in the ventricle firing discharges, and it's pre-VFib, right? Because it's multiple places in the ventricle discharging the heart. It's pre-VFib. So paroxysmal ventricular tachycardia says you have more than one focus in the ventricle firing discharges. Now, the prodromal to that is multifocal PVCs. If you have multifocal PVCs, you're going to be more at risk for paroxysmal VTach, multiple areas, firing impulses, because all those unhealthy areas actually reach threshold first. Okay. From that, we also remind ourselves that we can have an irregular atrial fib conduction through a right bundle branch block pattern. So it's a wide QRS, but we have underlying atrial fibrillation. Okay? So that's kind of straightforward. Then we move to narrow QRS and wide QRS bradycardia. Okay, so bradycardia, most commonly we see sinus bradycardia because of sinus ischemia, because we've used Presidex, because the patient's hypothermic, we've induced it, or they are just hypothermic. We also see sinus bradycardia as a warning sign in tension pneumothorax, where your heart rate goes down, but your blood pressure is tanked, and that's never normal. Problem isn't your heart, the problem is the compression of your heart from the occupation with air, right? That's what the tension pneumo does. Okay, AFib, A-flutter, that has been controlled aggressively with pharmacodynamics. We can also see on narrow QRS bradycardia because we're limiting the conduction through the AV junction. And we talk about first degree AV block, second degree AV block, third degree AV block. You have narrow QRS bradycardia, But of course, with second degree and third degree AV block, every P wave does not have a QRS. Then we talk about wide QRS bradycardia. Wide QRS bradycardia is very straightforward, okay? Very straightforward. You're bradycardic, your heart rate is less than the sinus node would fire at, 60. It might be 40, and it's wide. Well, that makes us think that this is an escape rhythm. It's called idioventricular rhythm or escape ventricular rhythm. What it means is your lowest level pacemaker, your Purkinje fibers, are firing into the myocardium, and that's at a very low rate. So remember, what our purpose will be is to stimulate the higher pacemaker, not to suppress the Purkinje fibers, because that's the only thing that's escaping you from death, right? That's the only thing that's keeping you alive. We also see if we have a bradycardia with a primary or secondary bundle branch block that the QRS will be wide. And we know that with complete heart block, what we call AV dissociation, atria is firing. Whoops, I'm going to put down my little thing here. The atria is firing at a regular rate, so P to P to P to P might be a rate of 70, but my ventricle is firing at an irregular rate. It's very hard for me to do this. I don't play the drums and I'm not very coordinated. So atria, 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 ventricle. Atria, 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 ventricle. But because I have a complete dissociation between the atria and the ventricle, what gets initiated from the ventricle is a basic idioventricular rhythm. So what do I need to do? Stimulate the higher pacemaker. So having given you this overall introduction, we're going to come back in our next segment, which will be Group 4, Class 4, on cardiac dysrhythm, and we're going to follow up on some of the dysrhythms that we see currently and most significantly at the bedside. Thank you very much.